moderate my talk. I think she had to stop me at some point, so please stop me because she's not being able to connect. And Rebecca was perfect for the presentation because I've been working with Rebecca for many years. I have been working with the MHAS data, specifically with the cognitive data for MHAS, and it's a long journey. We're now working on the MEXCOG, this subsample from the MHAS that was assessed and reassessed for specific cognitive performance. We have now a lot of things going on with the HCAP and the MEXCOG, but MHAS is still giving us a lot of work to do, and MHAS has now a lot of information that I want to bring out in this talk, especially to show most of the students who are here, how do we take advantage of all these survey data that we have about older adults in Mexico, in the US, but I'm being concentrated in the Mexican population. So first of all, I want to tell you that when I was thinking about the name of the talk, the only thought that came to my mind was Mexican population needs to be resilient to many things, to many conditions. I am not from Mexico. I am from Colombia. I came to live to Mexico 20 years ago. And as a psychologist and as a neuroscientist, I was aware of the so many factors that affect the health of the Mexican population, which many of them they are not aware of. And I think that's a very important point, because we need to understand that it's not that they cannot change that, but sometimes it's that they don't know that those factors are affecting their lives. And one of the scenes that I always have in my mind when I arrived to Mexico in the year 2000, the last time I came back to Mexico, I was working at the hospital where Luis Miguel Gutierrez was my boss. And the hospital is located in an area which concentrates many other hospitals. And on the way, on the road to the hospital, what you find is a lot of food carts, not food courts, it's food carts, street food down there, offering a lot of food, which if you look at them, I hope you're not hungry, because if this was around 12 or noon, we would be very hungry because all this food is so good, so good. But anyway, so this scene of watching this lot of street food down there in the middle of all the hospitals, because you walk to the hospital and all these stands are there. And guess who's sitting there? The patients. The patients who have obesity, who have diabetes, who have cardiovascular disease. And they are sitting there eating while they are waiting for their appointment to happen, or they are finished with that appointment and they're having their breakfast or their lunch or the food, the meal between lunch and and the next time. So it's permanently, you see people there eating and eating and eating. So if we look at this scene, you think, does Mexican population need to be resilient to their own eating habits? Eating habits that are definitely defining their health, but that they are not going to change them because of many factors, one of those being poverty, being health inequalities. So that's what they can eat, that's what they can afford, and guess it's the best food we can have. So is exercising a way of coping with this type of eating habits? Maybe for us, but not for them, not for them. Exercising will, if we explore exercising, we will have to move into other areas and understand that exercising is not available for them. It's not available if we think of parks where they can exercise. For example, Mexico is not full of parks for exercising. Anyway, so we can go on and on and on, and we will leave in this type of exploration. That will show us that being resilient in Mexico for the Mexican population is very hard. However, if we are trying to understand what is that makes the people resilient, we need to understand there are many factors that are playing a role, and that these factors are important in their own way, but they are important together too. And this is my review of the literature. So I'm not going to talk anymore about the review of the literature, because if you look at this slide, there are all the papers, well, not all, excuse me, some of the papers, many of you who are sitting here have written, many of you have been here in this meeting telling us about the results. And we have a lot of sources of information that will tell us how many factors are playing a role to define the health of the Mexican population. Many of these papers have been done using the MHAS data, and all the titles are very suggestive, and it's not one or the other that I want to point, but many of them, which I'm gonna go on further mentioning the factors, can be read in these papers and understand how are they playing this role in resilience. But let me go into the theme I have been working on during the last years, that is cognitive aging. So if we look at cognitive aging, now that I have presented all these, my point of view about Mexican population, and I think it's also your point of view, this social ecologic model of cognitive aging is as complex, we can make it as complex as we want. So I am mentioning a lot of factors that are influencing cognitive aging. And the model has a big benefit because it's talking to us about the different levels in which these factors are influencing the individual, who's most of the time the one we are studying. So if you look at the model, you can arrange these factors that I am just mentioning there, and that are part of the papers that I just presented, but factors which are part of the individual's own health, but they are also part of the family and social surrounding of the individual. Or we can go up and find some factors as part of the environment. And finally, the government or the public policies that are the ones that will let us understand how government changes, as we will see further, are impacting individuals' health. So there's the list, and that list, guess, I'm sure every factor that I am mentioning has been studied and has an impact on cognitive health. But the picture is not static. The picture is moving. We cannot think of the factors affecting individuals' health as something static. It's moving through the years. And this is a paper we wrote recently trying to understand what has happened between 2001 and 2015 with the MHAS data, and understanding how the cohorts that participated in 2001 and 2015 were different. And although many of those that are in 2001 are still in 2015, the cohorts have changed a little bit. So what has happened in these 14 years? The arrow is showing us what has happened. Everything has increased. The access to health has increased, but the BMI also has increased. The treatment for cardiovascular diseases has increased, but the cardiovascular conditions have also increased. And finally, education has increased. So all these forces that are like different in different directions have, what we were going to do is to look at the impact on cognitive aging. We wanted to see what happens between 2001 and 2015 in cognitive aging. But in this slide, the cognitive aging is not considered. I am only mentioning what is happening with these trends. And just take a look at education. Education has increased in the population 60 and over. If you look at the mean, it was 3.6 years of education in 2001. And in 2015, it's 4.9. Is that increase considerable? Is that increase significant to see a beneficial effect on cognition? No, it's impossible. So when we were discussing with the HRS team, which they published that prevalence of dementia decreased along the years, and they attributed a big part of it to education. Many of us thought, yeah, our education is also increasing, but it is increasing this amount, and a change from 3.6 to 4.9 years is not going to be beneficial for cognitive aging. Cardiovascular conditions, especially hypertension and diabetes, have increased incredibly from 2001 to 2015, 10% increase in hypertension approximately, and diabetes has increased terribly. But then we look at treatment, and we are so happy to see that treatment has also increased, and maybe it has increased because of two things. First, people are more aware of the diseases and they are consulting, and because there was a reform in the medical system, and the government opened access to health to this Seguro Popular at that moment, which everyone had access to, with many limitations, because now Seguro Popular has been greatly criticized. But anyway, it did the job. People had some kind of access to health that they didn't have before, as you see in the last line, where you see that 56%, 56.9 or 60% had access to health in 2001, and in 2050 it was 90%. And lastly, BMI. BMI is very, very bad, because as you see, obesity has increased from 16% to 20% in these 14 years. Okay, so this is the picture and how it is moving. So how is this impacting cognitive aging? And I'm not going to stay and talk about the rest of the paper and the results, but I am only showing you a little summary of our results. And they are showing that the overall prevalence of dementia in 2001 was 6.1%, and it increased to 7.3 in 2015. For males, the increase is 4.6 to 6.2, and for females, it was 7.3 to 8.2. So at this point, we have to think about a gender effect, sex inequalities, and anyway, the paper is there if you want to review it. It's very interesting what has been happening. But what I wanted to show is that the picture is also moving. Anyway, so to tell you what I did with the data on cognitive aging and to get into directly into the results about the analysis that I did, I want to briefly mention how we measure cognition in the MHAS. MHAS has this battery. It came from originally in 2001 from the cross-cultural cognitive examination that has the tests that are on the top. It measures constructional praxis, verbal memory, visual scan, constructional recall, and delayed word recall. So we are measuring memory, attention, spatial abilities. And what we have been doing is adding some other measures to try to capture many other things that are important for the classification of cognitive status in the older adults. And we added some questions on orientation, verbal fluency, backwards counting to measure speed processing, and the test of serial 7 to measure executive function or working memory. And the MHAS also has a proxy assessment, which is the IQ code, the Informant Questionnaire on Cognitive Decline in the Elderly, to measure cognitive status in the population, which because of health problems cannot answer the survey directly. And with all of this, with these two sources of information, the direct assessment through the battery, the IQ code, and the information about their activities of daily living, we construct our classification of cognition into normal, CIND, or cognitive impairment, no dementia, and normal. And this is the way we construct the variables. The variables are already constructed and in the data in the public place where you can access the data. And in the part mentioning constructed variables are the variables for cognition. So we have 5 waves. All the waves have information about cognition, classifying all the subjects in each wave. And we have a lot of individuals who have been followed up. So longitudinal analysis for all you students here is open in the MHAS data. It's there to be explored. So that's what I want to tell in the rest of my talk. They are all classified and you can work with them. How I'm doing on the time? Perfect. Okay, so what I did was a sample. I selected a sample from MHAS. I started in 2001. I selected all the subjects who were normal, and then I moved through 2018, selecting subjects only that were normal. Normal in 2001, 2003, 12, 15, and then I stopped in 2018, which is the last public available data that we have. So how many people are there? How many follow-up individuals do we have? We started roughly with 9,000 people normally classified there. And then we move and we end up like around 2,300 people in 2018. However, the analytic sample was reduced from those 2,300 that I last mentioned to 1,308 because I needed them to be consistently normal. And if you look at the data, you see that people move from one cognitive status to another because of many factors that are influencing the assessment of cognition in that day. Anyway, so they are moving, so we needed them to be consistently normal so that I can talk about resilience. I didn't want to mix people there who were not all the time normal. And this is what I get at the end. Normal was a trajectory where I have 1,097 subjects. Those who were normal all the time, and in 2018, they converted to CIND, 125, and 86 subjects who converted to dementia. The next step was selecting the variables. And this is very, very difficult because you have a lot of variables. So you need to understand which are the variables that are really important from the conceptual point of view and from all these results that we have mentioned before. And I selected 35 variables recorded using data from all the waves. Remember, I'm watching the people, the 138, the 1,038 subjects, all the waves. So these 35 variables were recorded. Only one thing, 7 of those 35 variables were not considering all the waves because they were only introduced in MHAS around 2012. So I didn't have the information of them for 2001 and 2003. And then I organized these variables in 4 dimensions: health, stress, psychosocial, and cognitive reserve, and constructed 4 indexes derived from the sum of the individual variables in each dimension. These are the indexes that I used. I named the first one a health risk index. The second one is the psychosocial index, a stress index, and a cognitive reserve index. I cannot stop to explain each of the variables because I would need like an hour more. But I can talk to you if you are interested about the constructing of these indexes. And then I went directly to see what these indexes were gonna show us about the sample that I selected. If you look at the descriptives, I don't know if you can see the numbers, they're very small, but you can see them. Very small. Okay, so the numbers are showing the obvious from the descriptive point of view for sex, age, and education. So normal, 56% were women, 36.8% were men were women for the normal CIND trajectory. Most of them are men. And for the dementia, 62.8 were women. And then education follows the trend that we expect from higher education to lower education in the dementia group. And there are the descriptives of the health, the psychosocial, the stress, and the cognitive reserve index. But I'm going to move to the regression analysis. When I did the multinomial regression analysis, obviously age and sex adjusted, not education adjusted because education was in the reserve index. So I didn't want to adjust for the variables that we were including. We wanted to see how the sex, the reserve index worked. And what I did was regress all these indexes on pathological cognitive trajectories. So if you look at the trajectory in normal dementia, you see what is the role of each index in the prediction. So it's the health risk index is associated with a higher probability of being in this trajectory. The psychosocial index is protecting people from being in this trajectory. Stress tends to be high, but it's not significant. And the cognitive reserve index shows the protection effect that we expected. And for normal and CIND, what we find was the health risk index showing the same high probability of being in this trajectory. The psychosocial index did not show anything. Stress showed less association with being CIND, and this is because the normal group had higher stress levels. And the cognitive reserve index showed the protection. If we look at it at the normal trajectory, so it's the same results, but concentrating on the normal trajectory, this is what we see: a health risk index that is lower, a psychosocial index higher, stress is not showing us anything, and cognitive reserve index is high. So what do I conclude about all of these things? One important aim that I was discussing with Rebecca lately is that we as researchers have to concentrate in the development and testing of the methodological approaches that will help us to predict. We have to move on to a prediction level, thinking to have all the information that we can to talk about who are the most vulnerable, who are the most resilient, and how these predictions can be tested further on through the other ways. Longitudinal analysis is the strongest research design for this aim. I know it's also the most difficult and time demanding, especially when you're working with survey data and you have to analyze all the information and be consistent, because it's not the same if you say being married is protecting people from cognitive aging. No, because if you look at the data, there's some people who are getting married and then they are getting divorced and then they are getting married again and then they are widowed. So selecting and concentrating the variables with an effect of the time is not so easy. I think MHAS and the Hispanic EPIC are gold mines. I don't know if the term is the same in English. We use it a lot in Spanish. They are gold mines because they have a lot of information open for further exploration, and we now have a lot of information which has been gathered by us and other researchers. I think that indexes have the benefit of integrating different sources of information, which otherwise will be analyzed as individual indicators. That's most of the papers that we have are working with these indicators individually. But this doesn't have an ecological validity because life in the surrounding people is not one thing, like I'm married. No, I am married and I have these stressful life events and I have these other conditions, and they are all moving in this picture that I showed, or I tried to show. The better indexes are those constructed with longitudinal data. I know the selection of the variables for the indexes is controversial. I know if I ask you all of you here, how will you construct a index for stress? You will have a lot of ideas, and maybe they would be different from my ideas. But the results I've shown are an example of how to approach the analysis of different dimensions that constitute the challenge of multi-resilience in the Mexican population. Thank you.
Thank you so much, Silvia. I want you to stay here just for a second. Jackie, would you like to join me Just give me 1 second. We were trying to get Rebecca to come in to say a few words. I know that she sent me the message. I wasn't open to open. Sylvia, it's with great pleasure that we want to thank you for being a strong participant of this series, for being such a great scholar in the field of cognitive health, like so much dedication and try to do all these methodologies, all these tests, try to get the best measure that we can. So we really want to thank you, Jackie.
Yes, and we're so honored to have you present this
thank you,
opening
Donna.
keynote address. It's a great way for us to begin our discussion of all these critically important issues. Dr. Mejia has been so instrumental in teaching us and elevating our sort of sensitivity towards measurement issues, these predictive models, which will be our big challenge as we move forward with this. So congratulations, and thank you so much for all of you, what you do for our conference series.
Thank you.
And we would like to
Thank you, Jackie. Thank you, Flavia. Thank you, everyone here, because I've been part of this meeting for all the installments, I think, since the first installment. I came from Mexico. Now I live in Tijuana, so it's a little bit nearer. But anyway, so it's been a pleasure to be here since the beginning and receiving this recognition and being invited as a keynote speaker was great. Thank you very much.
Sylvia, you're going to be
get the program.